any other entrance exams. You don't have to know everything, and you don't have to know everything in depth. Uh, Maybe it's just good to read once, because what AMC does is when they have a topic that they ask, say they introduce a new topic, a new question, they tend to introduce about 4, 5 around that same topic. So when you're like going through the new questions that have come up during the exam week, what you need to do is go to that guideline, read the whole thing so that you have an idea of the entire guide. You don't have to study it, right? So just get an idea so that when they ask you a question related to that, you're still able to answer. So rather than just looking at only the questions, yeah. But you need to use the questions as a guide uh, to help you, identify the breadth and the depth of the syllabus that they're asking, right? So we'll start with one of the common topics that they discuss is autoimmune myositis. Right? So you guys feel free to stop me and ask questions. And if you can't hear or if there's any problem, please stop me and let me know, right? Because sometimes I tend not to see the chat. Okay. So what is polymyositis, right? So it's basically a connective tissue disease, and it's an inflammatory disease. So there's inflammation that's affecting the muscles. So poly means multiple, myositis means myo is muscle, so inflammation of the muscle, right? So cause is unknown, and there is a possible background of a viral infection at the outset, right? And it's known to be more common in women than men, and they have the ages, the common ages that are affected is between 50 to 70 years. So this age range is quite important, because in AMC they will, if they are asking you about polymyalgia rheumatica or giant cell arteritis, they will always mention a lady or a male or female more than 50 years, right? So they are, that is something you need to note. If they give you something much less than 50 years, like say 30, 35, then you need to think about other things, right? So they are always particular about that age. So they will give you above 50 years. And uh, in many cases, polymyositis is associated with other autoimmune diseases. So again, AMC is very fond of associations, right? Uh, well, we will, like, as we go, we will give you all the associations that AMC talks about. So the reason why I say they're fond of association is when they're giving you a question, they will give you one of these background diseases. They'll say a known patient with Sjogren's syndrome, or a known patient with SLE. And then you might think it's a complication of SLE, but whereas they're talking about another disease that's associated with SLE, right? So polymyositis is associated with scleroderma, SLE, rheumatoid arthritis, Raynaud's, and Sjogren's. So these are all commonly associated with each other, right? Signs and symptoms. So just you don't have to memorize this, but have an idea, because when you get the question, they will give you these signs and symptoms. So you need to be able to relate. Okay, these signs and symptoms belong to this particular condition. So here, did somebody say something? Okay, so symmetrical muscular weakness of the shoulders and hips. So what do you mean by symmetrical? It means bilateral, right? So sometimes in the questions on AMC, they give it to you as bilateral muscle weakness. Uh, so symmetrical, bilateral, same thing. Shoulders and hips particularly. So PMR, you must think it's always shoulders and hips. So it's can be both, it can be one of the two, right? And here, what they have is a weakness, right? Sorry, this is polymyositis. So they have a weakness, uh, which is symmetrical and which affects the shoulders and the hips. So the rest of it, you just have to like have an idea. So associated with this muscle weakness, there's disuse. So they have atrophy. So there's muscle wasting, muscle pain, fatigue. When it affects the respiratory muscles, they feel breathless. When it affects the muscles of the face and the neck, they have swallowing difficulties, right? There can be associated tremors and gait problems, wide-footed stance, right? And clumsiness with tendencies to fall. Again, that clumsiness and to fall is because of the weakness of the hip girdle, right? So then their gait is affected. Polymyositis develops gradually over weeks or months. So this is another MCQ point to remember. Uh, it's progressive. So in the questions, they will give you as progressively worsening muscle weakness or progressively worsening joint muscle stiffness, right? So it develops over weeks or months. So they will give you a history of weeks or months, not years, right? And by the time the person experiences the symptoms, they have already lost around half of their muscle fibers to the disease. So they develop symptoms one after most of their muscle fibers have been destroyed. So the head, hands, and feet are usually untouched by the disease. So they will generally come with shoulder and hip joint problems. There will be profound muscular weakness in the body parts, unable to lift the arms above the shoulder height or lift the head off a pillow. So this is again another MCQ point. They will give you a question saying they are unable to lift their arms above the shoulder height. And one way they depict that is they say the patient has difficulty in combing their hair, right? So when they say difficulty in combing the hair, you need to understand, okay, they're talking about being unable to lift the arms above shoulder height, right? Then those swallowing difficulties, when the muscles of the face and the neck or the larynx are affected, then you can get voice changes, swallowing difficulties, bowel problems, where there's peristalsis also is affected, and then it leads to constipation, right? And contractures. So you just need to have an idea only of these symptoms, right? No need to study it in depth. Then there are some complications that come with polymyositis. Uh, Again, it's just due to the inflammation, right? So inflammation of the heart can lead to myocarditis, MIs, right? And they are also associated with malignancies, lung diseases, due to the poor functioning of the respiratory muscles. They can have pneumonia or fluid collection within the lungs, leading to various lung diseases, right? So that is polymyalgia. So we will go through the investigation findings all together so that you have an idea how to differentiate. Because sometimes when they give the question, they will give it, and in your head you'll think it's one disease, but there'll be one differentiating point that will lead you to the correct answer. So how do you get to that, right? So I will do like a comparison and show you. Um, so then dermatomyositis, like the name suggests, it is a myositis. Yes, it affects the muscles just like in polymyositis, right? But there's an additional skin related component to this, right? So dermatomyositis is not the same disease, but it's grouped with polymyositis because there are some similarities. What are the similarities? It's this muscle inflammation and the weakness of the muscle, right? So they will come with those same symptoms as polymyositis. In addition, they will have this skin uh, changes, right? So you can have dark reddish skin on the cheeks, throat, shoulders, and there'll be swollen and painful muscles, and they are mostly associated with cancers, right? And then there are two age onsets, right? One is children. That's the juvenile one is children between 5 and 15 years, but there's an adult onset myositis that occurs above 40 years, right? So if we just take a look at the, so for dermatology, there's no strict guideline or anything to follow on the Australian guidelines. What we generally go through is the derm net, right? So one second, I'll just see. So I'm just sharing the sorry, this is polymyalgia. It's a bit difficult to open with. So anyway, we'll just go through the polymyalgia rheumatica for the moment. What I'll do is, okay. So this is the derm net. I hope you all can see the screen that I've shared. Adult onset dermatomyositis. This is the guideline that we're following, right? So any skin related thing, you can go to DermNet, and you need to get, like when we're doing dermatology, we'll show you, you need to be familiar with the pictures as well, because most of the dermat questions are picture related, right? They'll give a picture and they will ask you, is this psoriasis? What is the treatment? They won't ask you if it's psoriasis, they'll just straight up ask, what's the treatment, right? So you need to come to your diagnosis and then go to the treatment. So DermNet has a lot of images, and at the exam, they give a lot of similar images from this website, right? So this is about adult onset dermatomyositis. You don't need to know everything, right? Peak age is 50 to 60. Um, it's strongly associated with malignancy, right? Just know that. And then there are some gene associations as well. So anti-Jo antibodies and HLA-B27, right? So remember that HLA-B27 anti-Jo antibodies, these can be associated with dermatomyositis. Uh, so the cutaneous features, so they can just maybe give you a picture and ask you to diagnose as well, saying a person with bilateral shoulder joint weakness or hip joint weakness, which is progressively worsening, difficulty in combing the hair, comes with a rash like this, right? So then what you have here is dermatomyositis, right? So not polymyositis. So this is a heliotrope rash, the kind of rash that occurs around the eyelids, right? Then the shawl sign. Shawl sign is again around the shoulders, chest, and back, like around the neck, right? Then they have the photosensitivity rash or the sunburn, and these are known as Gottram papules. So this is one of the features of dermatomyositis. These are purplish plaques and papules on the small joints of the hands, right? So on the dorsum of the hand, where the joints are, you get this kind of plaquey appearance, right? So for dermat, it's good to again have like a sort of an album on your phone or something. You can keep screenshots of these and add it to that album so that you can keep, looking at those pictures so you get used to it, because they have a lot of cancers, different skin cancers that they question on in AMC, right? So with pictures, they question on dermat mostly through pictures, right? So Gottron's sign is again the same thing, right? Uh, you can get it on the back of any joint. Then there's scalp involvement, uh, itchy scalp, right? Scaling, sort of scaly, itchy scalp. So you might confuse it with psoriasis, right? So nail fold changes, you don't need to know the exact, all these ragged cuticles and all of that. Just know there are some of these skin changes, right? These are, so they can be associated with Raynaud's phenomenon, right? That's one thing you need to know. So here's the myositis part. So it can occur in polymyositis, it can occur in dermatomyositis. So they might even say because of the hip girdle being affected, climbing the stairs or walking is also difficult. Rising from a sitting position or a crouching position. So these are things that they give in the questions. They don't say, hip muscles are affected straight off. Sometimes they will give you this kind of thing, lifting objects, raising arms above the shoulders, such as when combing hair. So this exact thing was there in a question, right? So you can uh, kind of understand they're taking it from they follow this guideline, right? So DermNet. How do clinical features vary in different types of skin? So these things you don't need to really know. And complications we did now. You don't need to know in depth the diagnosis, just know that you need to do a skin biopsy for dermatomyositis, and polymyositis, it's a muscle biopsy, right? So those are the two things. Yeah. So that was just to show you all the pictures and be familiar with it. So treatment wise, first line therapy, whether it's first, second, or third line therapy, all of it needs glucocorticoids. So you need steroids in. At any stage, you need steroids to treat this because it's an autoimmune disease. So any autoimmune disease will need steroids. But you can add to that on the initial stage, either methotrexate or azathioprine, right? Uh, if that's not responding, then second line therapy is MMF, tacrolimus, or cyclophosphamide. These are all immunosuppressants, right? Or you can go to a combination of methotrexate and azathioprine. That is, so first line was either one of these two. Second line, you can go for both together, right? And then third line is the MAB therapy, right? So in all three, you can consider IVIG, right, to treat the acute phase. Like if it's really severe, you want it to come down to a certain level that can be managed by oral drugs, you can give a course of IVIG. So this is just a diagrammatic representation so that when it's close to the exam, if you keep like one diagram in mind, then it's easier than reading notes, right? So symmetrical proximal muscle weakness, right? So that is bilateral shoulders and the hip joints, right? In polymyositis, the CD8 cells will attack this muscle fibers, right? And the diagnosis here is mainly muscle biopsy, right? And in dermatomyositis, you get these, like we saw the shawl sign, the heliotrope branch, the Gottron sign, right? So they call mechanic's hand when there are contractures and the fingers are bent in the way shown in these pictures, you call it a mechanic cell, right? So the antibodies were HLA-B27. You can add it to the diagram itself if you want, or have your notes on the side, add everything into one sort of a slide, right? Anti-Jo, HLA-B27, right? So again, just showing you how it's the proximal muscles that are affected, the hip, the thighs, the shoulders. Then you can get associated even chronic fevers, right? Mild low-grade fevers, fatigue, myalgia. Then it can affect the heart, the lungs, right? And there can be associated Raynaud's phenomenon. So this table I put here so that each of these diseases has a differentiating point that will help you in the question at the exam to identify, okay, it's this disease they're talking about and not the other one. Because like I said at the exam, they will make it look like one thing, but there'll be one point that will help guide you to the right answer, right? So from this table, I'm just trying to help you see how to go about that, right? So when you're studying for MC, this is how you need to sort of assess and study. Sorry, I didn't get the point. Yeah, this is how you need to study rather than going deep into the theory, right? If you can find the points that will help you come to the diagnosis and study mostly the managements, what is the next best management, what is the best management, right? Always the best management will not be the next best management, right? So those kind of things. So here, how do you differentiate polymyositis, dermatomyositis, and polymyalgia rheumatica, right? So, did I do yeah, PMR? So let's first go through the polymyalgia rheumatica. Anyway, in polymyositis uh, and dermatomyositis, both will have a progressive and symmetric muscle weakness, right? Progressive and symmetrical in both. And it's a muscle weakness, right? And how do you differentiate between the two? So when they say progressive, symmetric, and there's a muscle weakness, then you think of these two, right? So when it's weakness, it's polymyositis or dermatomyositis. And then you differentiate the two with the rash, right? So if there's a rash, it's dermatomyositis. Then if they say pain and stiffness instead of this weakness, muscle weakness. So in polymyalgia rheumatica, it's a joint, right? It's the same region, the shoulder and the hip. Here it's the joints. So the proximal joints are affected, mostly bilateral shoulders, bilateral hip joints, and there you get pain and stiffness. So they will not give you any statement suggesting muscle weakness. So remember that. If they don't give you a statement suggesting muscle weakness, if they're talking about joints, then you will exclude polymyositis, dermatomyositis, and go for polymyalgia rheumatica. But they might give a similar picture to PMR, that is polymyalgia rheumatica, but they will slyly in the middle of the sentence mention it's a muscle weakness. Then you need to quickly shift your diagnosis, right? So these are just like one or two differentiating points that you need to keep in mind. If you know these, you don't really have to read through the entire question. So that those questions are pretty long. It sort of covers the entire screen, and their question choices sometimes are just there slightly at the bottom of the screen, right? So they'll sometimes give you a lot of unnecessary investigations, so you wouldn't know whether it's needed or not needed. Are they trying to guide you to something or confuse you, right? So if you know these points, no matter what they give on the side, you have come to your diagnosis, right? Then inclusion body myositis, again, it's a slow onset asymmetric muscle weakness. So here, they haven't really questioned directly on this. This has been just like one of the choices, but it has never been questioned directly, right? And if they're talking about an HIV myopathy, you'll obviously get a detectable HIV viral load, right? Drug-induced myopathy, so we will do that. How you differentiate between drug-induced PMR, dermatopolymyositis, right? That is by investigation. So in drug-induced myositis, myopathy, you will get like similar features. Either joint is affected or mostly it's the muscle, right? So they might say symmetrical muscle weakness. And the patient was taking statins or steroids long term or something. But actually, the answer is uh, PMR or polymyositis, right? So, how do you come to that conclusion? Again, from the investigation. So, we'll check that. Lupus myopathy, here you will get one of these tests positive, right? ANA, anti-Smith, anti-dsDNA, right? So, just remember these differentiating points. And I will just show how to differentiate between drug-induced and the rest of it. So statin-induced means drug-induced, right? So what are the investigations they do? ESR, CRP, and creatinine kinase. So I think we did this in that first lecture as well. I showed you this table. Polymyositis, dermatomyositis, and statin-induced myositis, you get all of these three elevated, right? So there's a confusion here about whether CK is elevated or not in statin, but the guidelines say specifically, even in the research papers, it says statin-induced myositis does elevate the creatinine kinase. So if they're giving you a muscle-related thing, weakness, with a patient who is on long-term statin or long-term uh, prednisolone, colchicine, any of those drugs leading to myositis, you can pick drug-induced myositis provided there's all three of this is elevated, right? But if they give patient on statin having this features of polymyositis and also give you a skin change, then you need to go for dermatomyositis, right? Adhesive capsulitis, we'll do it next. That has no changes on the investigations. And in polymyalgia rheumatica, you must remember their ESR and CRP are only elevated. It's a joint stiffness and pain. So remember, rheumatic means joints. So polymyalgia rheumatica is joint, they give a stiffness of the joints and the stiffness and pain of the joints, right? So as a result, your CK will be normal. So that's how you remember it. So these are affecting the muscle. So muscle enzymes will be high. But this doesn't affect the muscle. So the muscle enzyme is normal, but the other two are elevated. And particularly in PMR, the ESR will be above 40, right? So that's one of the diagnostic criteria. So we'll follow it through with the guidelines, right? So just a bit about adhesive capsulitis. So this has been one of the choices on the stems, right? So just to know a bit so that you can exclude it if at all in a question, right? So this is a pain, again, it's progressive and it's painful. And what happens is it the muscle or the joint? It's actually the joint capsule, right? It's neither the muscle or the joint that is affected, it's the capsule, right? So the capsule of the shoulder joint. And as a result, there's progressive loss of shoulder motion or range of movement is restricted. So unlike in polymyositis, PMR, dermatomyositis, here it's the problem is with the range of motion, right? And active and passive movements of the shoulder joint are affected. And what is the capsule? It's the glenohumeral ligament. So glenohumeral ligament is another name for the shoulder joint capsule. So here you can see this is an inflamed capsule, right? So this is another name for this adhesive capsulitis is frozen shoulder, right? So here, this is the hallmark. So inflammation leading to contraction. So when that occurs, you have decreased range of motion, right? So again, similar age range. So that's why they give it as a STEM or one of the selections in those questions, right? So to see if you can are able to exclude it, right? So those who had stroke, thyroid disease, Parkinson's, mastectomy history, and those who had any shoulder injuries, right? So they can all come with it. Clinically presents as pain, stiffness, and dysfunction, right? Of the affected shoulder joint with decreased range of motion, especially external rotation, right? It's self-limiting but can persist for years. So cause is unknown, but high prevalence with DM and hypothyroidism, right? So this is from the guidelines. Just know these points so that you are able to exclude it in the questions, right? Although imaging is not necessary to make a diagnosis. Coracohumerals, this is another name for glenohumeral ligament. Coracohumeral ligament thickening on MRI is highly specific, right? So then you get their treatments are NSAIDs, oral steroids or intraarticular steroids if it's oligoarticular, right? Physiotherapy, acupuncture, and those are all like side stuff, right? So physiotherapy and corticosteroids are the mainstay, right? So those two have to be combined. And surgical treatment if there's no improvement after 6 to 12 weeks of the non-surgical, right? So we'll do something on PMR. So again, polymyalgia rheumatica is a common question that has been asked in the past, right? So hallmark is bilateral, that means it's symmetrical again, right? So bilateral shoulder and hip girdle pain with profound stiffness, pain and stiffness, right? And stiffness may be so profound that patients have difficulty in turning over in bed, rising from a bed or a chair, raising their arms above the height of the shoulders, right? Like combing their hair. So this is from that guideline. Um, I'll show you the guidelines as well. So let's, so that you all have an idea on. So this is the this AFP guideline is actually the what the Royal College of Physicians follow. These are the guidelines, right? So this is an updated one, but it's not very recent. It's 2014. That's the latest one that's available, right? So you have a little, you can just have a go through with this. I will tell you what's important. So this is what they're saying. The stiffness may be so profound that they had difficulty in rising from a bed or a chair and all that, right? So there are some new diagnostic criteria. So they have compared it with the old diagnostic criteria, right? Uh, so we'll see here. Initially, they've given this thing of duration more than 2 weeks. Uh, yeah. So that has been removed now. I'm sorry. I'm trying to get but I cannot. So that has been removed now, and they just go with this age of 50 or more, right? Equals to 50 or more. So most of the questions they say 50-year-old female, right? Uh, Here they say the first one is new bilateral shoulder pain, and then another point is new hip involvement. So it doesn't come together, right? So morning stiffness more than 45 minutes, that is there, right? So what they mean by this being divided into two separate sections is you can have only shoulder pain, only hip pain, right? Either one can be taken. And CRP and ESR are elevated. Absence of peripheral synovitis or positive rheumatoid arthritis serology, and then some ultrasounds can find it. So bursitis, tenosynovitis, glenohumeral effusions, right? So if they give you glenohumeral effusions, just go through the rest of the history. Is it bilateral, symmetrical, above 50 years, progressive, all of that, so that you can differentiate it between adhesive capsulitis and polymyalgia rheumatica, right? So then here they've given some clinical features with the disease, right? These are conditions that can mimic polymyalgia, but I won't be going to this because this is not that important for your questions, right? So these we will go uh, when we are doing osteoarthritis or spondylosis, right? This so we'll come to this when we are doing GCA. So this particular guideline talks about polymyalgia rheumatica as well as joint cell arthritis, right? That's because both of them are associated. So again, they are very fond of associations, right? So this is the table I've taken from the guideline, what I showed you all now, right? Uh, and then this is also there on the guideline. On that same guideline I showed you. So it's recommended that the clinicians assess the bone mineral density before initiating corticosteroids. So there is a question that will ask you about initiating this corticosteroid. They will ask you, will you go for a bone mineral density first, right? Or would you give calcium and vitamin D3 together, right? So it has been suggested that if the treatment of with steroids is going to be more than 3 months, then you need to also start them on calcium and vitamin D3 supplementations, right? And you need to assess their bone mineral density in the lumbar and the hip spine, right? Lumbar spine and the hip, and bone mineral density, if the T-score is less than 1.5, suggesting osteopenia, then you need to go for bisphosphonates uh, because the calcium can worsen their osteopenia into osteoporosis, right? So remember this particular slide, not only for this polymyalgia rheumatica, for any condition where they are going to start long-term steroids as a treatment, if they ask you this particular slide is true, right? So there have been stems like this, start them on calcium and vitamin D3 together with the steroids, or go for a bone T-score, right? So what is giant cell arteritis? So here, some of the symptoms that you need to know is, which is kind of, it's pathognomonic for GCA, right? One is the temporal artery tenderness and headache, jaw and tongue claudication, right? So sometimes they say there's jaw pain when chewing or opening the mouth wide. So this has been in a question. Instead of, they don't really mention jaw claudication straight off. They say that the patient comes with pain on chewing, right? And visual loss or double vision. So again, from the guidelines, GCA should always be considered if in the differential diagnosis because it occurs in 16 to 21% of the patients with polymyalgia rheumatica, right? So here is an association. Commonly, AMC asks questions on PMR using ask questions on giant cell arteritis using PMR as the backgrounds. They will give you a full picture of polymyalgia rheumatica and then tell you the patient has some temporal artery headache or blurred vision, right? So then your diagnosis should quickly change there. You should remember, oh, polymyalgia rheumatica is associated with giant cell arteritis. So therefore, they must be talking about now giant cell arteritis. Why would you check that first? Because that is the emergency, right? So that is an acute condition that needs urgent treatment more than PMR, right? So are you going to start them on low dose corticosteroids and treat their PMR when they come to you with blurred vision? Or are you going to go straight off for the treatment of giant cell arteritis first, right? So obviously you will treat the giant cell arteritis first. So again, whenever GCA is suspected, thorough clinical evaluation should be performed and should be supported by the measurement of inflammatory markers and temporal artery biopsy. So this is ESR, like sometimes you get a 3-figure ESR and then temporal artery biopsy positivity. So this part, tab-based temporal artery biopsy, it should not delay the prompt institution of high-dose corticosteroids if GCA is suspected. So this is what I was saying. So this is a actual AMC MCQ. They have again taken it directly off their guidelines, where they give you one stem saying, you have to start corticosteroids after you get the temporal artery biopsy reports, right? Or after you have taken the sample for temporal artery biopsy, only you can start corticosteroid. That is what they give as a stem. So that is false, right? Uh, their guideline itself mentions do not delay the institution of corticosteroids for a temporal artery biopsy. So you can give the high dose of corticosteroids immediately at your practice, at the GP practice, and then slowly go for a temporal artery biopsy, because you need to do it at a proper timing during the day. There should be availability of labs to accept the samples. So say the patient comes in the middle of the night, you can't be doing temporal artery biopsy, right? So what they say is giving high dose of corticosteroids does not change the temporal artery biopsy results, right? So, and you have 1 week to perform this tab after starting corticosteroids for this patient, right? So there is time. Diagnostic criteria. So this is according to their RSCGP guidelines, so they are following the ACR guideline as well. Diagnosis may be made when patients meet 3 of these 5 criteria listed. So again, if you notice, age is more than 50 years. So it's easy to remember, right? So that's why they tend to confuse you with all of these first few conditions that I have spoken. Polymyositis, dermatomyositis, polymyalgia rheumatica, giant cell arteritis, and yeah, those things, PMR, yeah. Those all you need to think about it when they talk about a 50-year-old patient coming to you, right? So think about all of these possible conditions. New onset of localized headache. So they will say a patient with polymyalgia rheumatica comes to you with a headache, right? Temporal artery tenderness, decreased temporal artery pulse, and ESR is 50 or more, right? So in polymyalgia rheumatica, if you remember, ESR is higher than 40. That is one of their criteria. So ESR more than 40. But when it's giant cell arteritis, ESR more than 50, 50 or more, right? And a positive temporal artery biopsy, that is diagnostic, right? So treatment-wise, For both, again, it's steroids, right? So first line treatment is always steroids. In giant cell arteritis, uh, you sort of bombard them with a high dose of steroids and then tail off. So if you look at this, you don't need to memorize this regime. This is from their guidelines, but just know that the initial dose is 40 to 60 milligrams over 4 weeks, right? And then, if you notice, they're reducing it every 2 weeks, 2 to 4 weeks, then 1 to 2 months. So obviously, the regime is going to go on for more than 3 months. So if they have a high risk of osteoporosis, they need to be started on calcium, vitamin D, and you need to check their bone mineral density, right? Polymyalgia rheumatica, it's a lower dose over a longer period. So 15 milligrams for 3 weeks, right? So then you start tailing it off. You don't need to know these tail off regimes, right? So mm, this is from their guideline, right? So the AFP guideline, that is the RSAGP guideline, basically. GCA should always be considered in the differential diagnosis because it occurs in 16 to 21% patients with PMR, right? So this is this is another thing that is important for you. And this is what I already gave, right? So investigations like we saw, those inflammatory markers are needed, right? And this is their pharmacotherapy. So reading all of this is going to take you a long time. I mean, since you have time till the February exam, you can read it once, but if there's anything you need to add, just add it on the side. So that next time you're going through the guideline, you don't have to read this, right? So have all of these in one place. Again, this table, you just need to know this first line and have an idea that it's a tail of regime, right? And yeah, this is the one where they've asked you to, if it's taking longer than 3 months, you go for this, right? So what we discussed. Yeah. So this is another consideration they have, right? Corticosteroid sparing agents, such as methotrexate, azathioprine, you can consider if they have any corticosteroid related adverse effects. So they always have these key points at the bottom, right? It's good to have a read through just in case you miss something when you were scrolling through. There are some important points inside this, right? So any questions so far before we go into the next one? I mean, you can put your questions in the chat box also. I will answer when I see it, right? Any questions? So we'll go to the next set of diseases, right? Uh, I'll give you all a 15-minute break around 6:45. Yeah. So that group that we did now, the group of diseases, they all tend to have certain similarities. That's why I put it together, right? Dermatomyositis, polymyositis, polymyalgia rheumatica, adhesive capsulitis, right? And then the associated giant cell arteritis, right? All of them have this similar shoulder and hip girdle, hip joint or muscle involvement. So sometimes it's such as PMR, it's joint. Polyendomyositis is the muscle, right? And in certain cases, it's weakness, and in certain cases, it's stiffness and pain, right? So those are your differentiating points. And when you see a question, you should be able to identify, right? And then when you identified PMR, if they are giving you any other symptom that is related to uh, giant cell arteritis, go for giant cell arteritis diagnosis, because that is what needs the acute treatment to prevent permanent blindness, right? So the problem with giant cell arteritis is that it affects the vision, right? So it causes permanent blindness. So this is about the temporal artery, where you have emboli going into the retinal arteries that is causing permanent blindness, right? So it's not reversible. That's why you need to act quickly. So if they're giving you polymyalgia rheumatica picture, always go for with a giant cell arteritis features. Your whatever answer you select should be treatment for the giant cell arteritis, right? So we'll do questions, then you will understand how to get about it, right? So then rheumatoid arthritis, again, you don't need to know all of this in depth, just enough features to be able to diagnose it at the exam, right? So here, pain and stiffness of more than one joint, right? So the newest thing with rheumatoid arthritis is you can even have one joint being affected, right? If there are other features as well. So pain and stiffness of more than one joint, one or more joints, right? Morning stiffness lasting more than 1 hour, and tenderness and swelling over the joints, right? Decreased range of motion, and then generalized features such as low grade fever. You get it in most of the chronic diseases, fatigue, malaise, right? So just remember, stiffness in rheumatoid arthritis, stiffness is more than 1 hour, right? And any inflammatory arthritis versus mechanical arthritis, right? So such as osteoarthritis versus inflammatory arthritis like rheumatoid, right? Uh, with inflammatory arthritis, uh, the pain eases with uh, movements, right? And or exercise. But with uh, mechanical osteoarthritis, the pain worsens with exercise. So at the end of the day, if the pain is worse, it's suggestive of osteoarthritis. And if the pain gets better towards the end of the day, then that is possibly rheumatoid arthritis, right? So this is the latest European classification along with the American College of Rheumatology. This is so a lot of the Australian RSCGP guidelines, they have, if you saw what I showed now, PMR and all of the others, they refer to this ACR guidelines. So no harm in going to the ACR guidelines if you can't find the RSCGP guideline, right? So in rheumatoid arthritis, this is their latest classification, how they give the scores, right? So you don't need to know these scores. If more 6 or more, it's definitely rheumatoid arthritis. So know that if it's just one large joint, you don't get a scoring there, right? And then there are certain serologies that you need. one is rheumatoid factor, other one is anti-CCP antibodies, right? Then you also need an ESR or CRP to be high, right? Duration of symptoms also matters. If it's more than or equal to 6 weeks, then there is a chance that it is rheumatoid arthritis, right? So duration more than 6 weeks, pain and stiffness more than 1 hour, affecting more than one joint, right? And these are the investigations. So basically from this table, you can gather all of those. So what are the investigations you do? Rheumatoid factor, anti-CCP, antibodies, CRP, and ESR, right? So for patients with at least one joint with definite clinical synovitis, not better explained by other diseases, you need to first rule out these. So once it's ruled out, you can come to this diagnosis, right? Otherwise, if it's just one joint, it's hard to get this score of 6 or more, right? But if you have excluded it, you can come, right? And notice here, when they're talking about the joint involvement, they don't mention anywhere that it has to be symmetrical, right? So back then, the thing was that the joint involvement had to be symmetrical, right? But now, uh, they say it does not have to be symmetrical, right? So remember that. So they will give you a picture with one side only being affected, right? So if it's just one joint, then you need to think about the other inflammatory arthritis. So what are these inflammatory arthritis? One is psoriatic polyviral arthritis, gout, CPPD is pseudo gout, and SLE, right? So these kind of arthritis, the pain will improve with exercise, right? Exercise or just working, right? So here, rheumatoid arthritis, usually it's bilateral and symmetric polyarthritis. So it does not have to be, it's not a, like you see here, it's not a criteria, right? So it can be unilateral as well. So usually it's bilateral, symmetric polyarthritis. So mainly there is actually what is going on here is a synovitis, right? So that's why they have all these soft tissue signs. When you look at the fingers, there's edema, swelling of the soft tissues around the joints. So that is due to the synovitis, right? And it affects mainly the small joints of the hands and the feet, but it can affect other joints as well, right? Any joint lined by a synovial membrane may be affected. However, extraarticular involvement of organs also are significant. So what are these extraarticular organs? We'll go through some pictures, right? Rheumatoid arthritis is theorized to develop when genetically susceptible individuals, that means they have some gene that will predispose them into developing rheumatoid arthritis later in life, provided they are exposed to some triggers like cigarette smoking, infections, like certain viral infections can lead to it. Like currently, we are seeing the whole spread of chikungunya that can lead to uh, long-term arthritis. Some people end up getting rheumatoid arthritis after that. That is because they probably have these genes, HLA-DR4, HLA-DR1, and they have experienced now a trigger, right? The trigger was the chikungunya infection. So now that's leading to an autoimmune reaction and rheumatoid arthritis, right? So not everybody who has this gene will end up getting the disease, right? So there need to be an environmental trigger, right? Signs and symptoms in most patients with rheumatoid arthritis, it's an insidious, so slowly progressive onset, right? And initially they will give generalized symptoms of fever, malaise, arthralgia, weakness, right? Then later on, they progress into this joint inflammation and swelling. So initially, they'll just have some very vague symptoms, right? So here it can be symmetric, it can be asymmetric. Remember that, right? So persistent symmetric polyarthritis of the hands and feet, if it's there symmetrical, it's a hallmark feature, right? So having symmetrical polyarthritis is a hallmark feature, but it's not a must, right? Progressive articular deteriorations, the uh, joint capsules and all get eroded, right? And even the joints, there'll be erosions, extra-articular involvement, and difficulty in performing the activities of daily living, ADLs, right? Constitutional symptoms and periarticular osteopenia, right? So there's thinning, or they have almost transparent sort of bones. So periarticular osteopenia is around the joint. There is osteopenia. Right? So that's important because that comes in one of the MCQ questions, right? So a similar picture has been there in one of the past MCQs as well, right? So this fusiform swelling of the fingers is suggestive of rheumatoid arthritis. Obviously, they'll give you a background history, right, and some symptoms. There'll be tenderness, pain, right, stiffness. Along with that, if you see a picture like this is due to the soft tissue swelling around the small joints. So fusiform, sort of sausage-like fingers, right? Patients with rheumatoid arthritis are they typically present with pain and stiffness in multiple joints, wrist, and proximal interphalangeal, right? So always now, I think we just recall this joint along the knuckles is your metacarpophalangeal. This is the interphalangeal joints, right? So this is important to keep in mind when you're doing all the other osteoarthritis and stuff as well, right? Um, so wrists, proximal interphalangeal, and the metacarpophalangeal joints are most commonly affected. So rheumatoid arthritis is this joint, this, and this, right? So proximal joints. And morning stiffness more than 1 hour suggests inflammatory etiology, right? So it could be any inflammatory arthritis if they tell you morning stiffness more than 1 hour. Symmetric arthritis is also not required according to the 2010 criteria, allowing for early asymmetric presentation. So at the onset of the disease, they can come with an asymmetric presentation. So there are some questions they give, like where they have shown you only one side being affected, and the answer is actually the rheumatoid arthritis, right? So they'll give some other features suggestive. So these are just for you to have a look at the deformities that are associated. Uh, Again, no need to memorize. Just know that these are the deformities that when it comes in the question, you can, you have that sort of a picture memory going to you. Okay, this is the picture for rheumatoid arthritis, right? So ulnar drift, uh, subluxation, that is basically subluxation is when there's it's a partial dislocation, right? So it slips beyond its joint slightly. Then you can get wrist subluxations. Then this is the swan neck deformity, Boutonier's nodules, right? Boutonier's nodules occurs when the damage of the tendon that lies above this joint. So there's a tendon that's connecting these two interphalangeal joints. When it gets inflamed and damaged, this two bony structures tends to pop out, right, through that damaged or loosened tendon like a buttonhole, right? So just check for some pictures of Boutonier's deformity. You see like a buttonhole deformity. That's the meaning of Boutonniere, right? Z-shaped deformity. So just know that these are there, right? Then I'm going to ask you what are the deformities. What happens is they will put it in the middle of a question, right?
So again, atlantoaxial subluxation is also one of the features, right? Uh, then you get some extraarticular features. Scleritis, Sjogren's syndrome. So we'll do about Sjogren's syndrome. So remember, Sjogren's syndrome and rheumatoid arthritis, Raynaud's phenomenon, all are associated. So here you have Raynaud's phenomenon, sensory motor polyneuropathy, Sjogren's, rheumatoid arthritis associated, right? And just have this picture in mind for the extra articular features. So it can affect the heart, right? Bursitis of the around the tendons and the muscle sheaths, right? Tendon sheath swelling, tenosynovitis, amyloidosis, and then you get the lung can get affected. There can be effusion, fibrosing alveolitis, lung nodules. So these are the anemia of chronic disease. So if you do a full blood count, that's can also give you a hint into the diagnosis. If they give you sort of an anemia, right? Ulcerations. So there's no pathognomonic test, right? You need to combine your clinical lab and the imaging features to come to a diagnosis. So, like, like I said, from the table, we gather ESR, CRP, rheumatoid factor, and anti-CCP. So other stuff you can do is a full blood count to look for anemia, anti-nuclear antibody to exclude other associated autoimmune diseases, right? So these are the common treatments. Uh, So you can, first line is generally NSAIDs, right? And according to their guidelines, NSAIDs has been shown to sort of slow the progression of disease, right? And then if it becomes worse, you can go for DMARDs, steroids, and then the MAB therapy, monoclonal antibody therapies, right? So these are the second, third line, but no, the first line is NSAIDs. DMARDs just have an idea about the names, right? These are the monoclonal antibodies. MAB is monoclonal antibody. So those are the biologic agent DMARDs. These are the traditional DMARDs. These are methotrexate, sulfasalazine, HCQ, and leflunomide. So these are commonly questioned around. Uh, Methotrexate in combination with other DMARDs as initial therapy. So remember, this is the updated guideline. Previously, DMARDs was considered towards as one of the last resort therapies after, you know, the initial NSAIDs, corticosteroids, all of those fail, then and methotrexate also fails, then you go for uh, MAP therapy, right? But here they say go for these DMARDs straight off in combination, uh, as in go for methotrexate in combination with other DMARDs, right? So methotrexate itself is a disease modifying anti-rheumatoid drug, that is DMARD, right? So methotrexate itself is one, but you can add another one. So mostly it goes with a MAB therapy, right? So consider the both of those in combination as initial therapy. So remember this. This has been a question. Uh, they tend to ask you in AMC a lot of the questions are what is your, like I said, what is your next best management or what is the initial treatment, right? So this is straight off their guideline. Initial therapy, you consider methotrexate plus another DMARD, right? And there are some surgical approaches. You don't need to know them in detail, right? Just know that there are some surgical approaches. Um, So rheumatoid arthritis actually it's quite a vast guideline. It's on the ACR. Uh, you don't have to read that whole thing. I've given everything you need on this. Uh, it's a very crowded guideline. So this is the ACR guideline for rheumatoid arthritis, right? It's a bit too much for AMC. Just So it was from this that they are saying you can combine both, and there's a question, right? So they have their tables. You can go through it leisurely if you want to, but it's not a must, right? Everything is there on the slides. So we'll remove these so that anyway. So while we're doing rheumatoid arthritis, it's good to know a bit about osteoarthritis because those two are what they tend to confuse you with, right? So they'll give us presentation similar to osteoarthritis, but your diagnosis will be rheumatoid arthritis or the other way around, right? So how do you differentiate? So diagnostic criteria for knee osteoarthritis. So osteoarthritis can occur in any joint, right? So if it's knee, again, you will have knee pain plus at least three of the following. So morning stiffness that is lasting less than 30 minutes. That means it's a mechanical arthritis. So when you start moving or exercising, the pain goes off, right? Crepitus when moving the knee, right? So when you palpate, you'll feel crepitations. 50 years again, bony enlargement, no warmth or tenderness, right? So sorry, no warmth, but you get a tenderness, right? So this is for osteoarthritis of the knee joint. So if you can see uh, on the x-rays, so there are certain x-ray features of osteoarthritis you need to know to be able to answer their questions. So we'll do it with the mnemonics as well. So like you see in this, there is, as compared to the normal joint space, the joint space is lost, right? So there's loss of joint space. And then if you notice, subchondral, that means just below the lining of the bone here, there's like a darkened white line. So this is a sclerosis that is occurring. That's called subchondral sclerosis, right? So here it's a uniform color around here, but here this border is more whiter than the rest of it. Okay? Another thing you need to notice is how white the joint is. So that means there is no thinning of the bone. There is no osteopenia, right? So where did we do osteopenia now? It was in rheumatoid arthritis, right? So rheumatoid arthritis has osteopenia, but osteoarthritis, if you can see, there is no osteopenia. So again, just everything in one picture. Mainly osteoarthritis, again, joint pain, deformities, immobility, stiffness less than 30 minutes, right? Symptoms worsen with activity, improves with rest. Okay. Then pathogenesis is there's progressive degeneration of this joint and the cartilage around, right? So there'll be some inflammation as a result. That is why you get the tenderness, right? But obviously, it's not an infection, so there's no warmth like in septic arthritis, right? So then you need to know this Heberden's node and the Bouchard's node, right? So we remember this as HD and BP, right? You can remember one of the two, HD or BP, right? So Heberden's is for the distal interphalangeals. Bouchard's is in the proximal interphalangeals. So these are sort of soft tissue enlargements like nodules that come in the fingers in the within the joint, right? It's palpable on the outside. So as you can see here, his finger, the margin of this, the outline of this finger is jutting out. So it's a palpable sort of an enlargement, right? A nodule. So Heberden's in the distal, Bouchard's in the proximal. So if you can see the joints that are affected in osteoarthritis, right? Uh, it's the distal interphalangeal joints mainly, right? So we'll just look at this in the proper x-rays, right? So the picture here shows where osteoarthritis and rheumatoid arthritis both are affecting all these joints. The yellow, right? Osteoarthritis only, so it can occur in the axial skeleton as well. So that is another differentiating point you need to know. Rheumatoid arthritis does not occur in this axial skeleton, right? It's mainly the peripheral joints. But osteoarthritis can affect any joint, right? Are you clear so far? Because no one's talking, so anybody, is it clear so far? Okay, I have just one yes there. So please feel free to stop me, ask questions, right? So it's just the first day, so I guess everyone's not that interactive, but once we start doing discussions and then sharing stuff on the WhatsApp group, so you can always, if you have questions, you can put it in this chat box or you can ask on the WhatsApp group. We'll be, even though lectures are on Wednesday and Saturday, we'll be helping you out throughout the week, right? So yeah, so here remember these two. If it comes in the interphalangeal joints, there's a bony protrusion in the interphalangeal joints, that is Heberden's or Bouchard's, right? And that is suggestive of osteoarthritis, right? Uh, so what was the rheumatoid arthritis? What was affected? Let's just go through that so that you're clear there, right? Proximal, wrist joint, metacarpophalangeal, and the proximal interphalangeal, right? So these three. And then osteoarthritis, as you can see, the difference is the distal interphalangeal joints, these two, right? So when you're talking about the hand, right? But osteoarthritis can affect anywhere, including the axial skeleton, right? And again, another difference, the morning stiffness, right? Rheumatoid is inflammatory more than 1 hour. Osteoarthritis is mechanical, so less than 30 minutes of stiffness. That is how they will give it to you in the question, right? They might even say just 30 minutes of stiffness. So that means they're looking for a mechanical thing. And then whether it worsens with activity or not, right? So this, it's from the ACR guideline. You don't need to know the sort of the details that are in here. Just put this for you to know that there can be osteoarthritis of the hip, hands, knees. So we have particularly gone through the hand, right? Hard tissue enlargement of 2 or more distal interphalangeal joints. So this hard tissue enlargement is what you see on the outside as Bouchard's and Heberdens, right? Then metacarpophalangeal joints can be swollen, but it will be less than 3, right? So if it's more than 3, if it's a metacarpophalangeal, you're thinking of rheumatoid, right? So no need to know these, just to know that there can be osteoarthritis of the hip also, right? So you can get a hip pain, and the osteophytes will be there in the femur or the acetibular region, right? Joint space narrowing, so we'll do that. And then knee. For knee arthritis, they say age more than 50 years. So I think we did that. Age more than 50 years, stiffness less than 30 minutes, crepitus, right? And these bony outgrowths or bony spurs, right? So this was the knee thing, older than 50 years, right? So remember this mnemonic for the X-ray findings of osteoarthritis and rheumatoid arthritis. So it can be confusing, but just know these points because there is an MCQ that has been asked around the X-ray findings, right? So so what happens is they'll give you symptoms uh, that are suggestive of uh, rheumatoid arthritis, right? So when you're reading the question, you will think, oh, this sounds exactly like a rheumatoid arthritis. They might say symmetrical, they might tell you small joints are affected, right? And at the end in the X-ray, they might say there was osteopenia, right? So when you say osteopenia, uh, they say there's no osteopenia. Sorry. So they'll give features of rheumatoid arthritis. They'll say there's no osteopenia. Then no osteopenia means osteoarthritis, right? Or they might give you features of osteoarthritis, and you will have in your mind, okay, this sounds like an osteoarthritis, but they'll say the X-ray shows uh, thinning of the bones, right? Thinning of the bones is rheumatoid, right? So the mnemonic in osteoarthritis is loss. Mnemonic for rheumatoid is less, right? So you remember O and O, right? Osteoarthritis, LOSS, right? So loss of joint space, that is narrowing of the joints in osteoarthritis. Osteophytes, these are those bony protrusions or spurs that they were talking about in the ACR guidelines. Subchondral sclerosis. So I'll show you in pictures so it's easy to remember. Subchondral cysts, right? So if you notice, I've just highlighted it, no osteopenia. So the reason I highlighted is it's important for your MCQs, right? And also remember to like keep in mind some of the pictures of these X-rays because those can also come in your exam and they can ask you what is this, right? So again, they'll confuse you. They might give you a history that is depicting rheumatoid arthritis, but this X-ray might be osteoarthritis, right? So they do that. So this is a normal joint, uh, and this is rheumatoid arthritis. So in rheumatoid arthritis, certain things you see like bony erosions, right? See, can you see that the joint is completely damaged? Like there's something called a rat bite joint, where it's like there's a rat bite in the joints, right? So it's all damaged and bony displacements, that is your deformities, right? So you get those Z-shaped swan neck deformities, Boutonniere deformities. So there's subluxations, displacements. And then if you see the bones are very thin, like it's blackish. So ideally it should appear white. So that is one feature, that is osteopenia, right? Then if you take the normal knee versus the osteoarthritis knee, right? Uh, what was osteoarthritis? It starts with an O, so LOSS, right? So remember it like that, loss. Loss starts with loss of joint space, right? So this is the normal joint space. Like you see here, there's no joint space, right? Then you get these bony spurs, like these bones are jutting out, osteophytes, right? Bony spurs. And then subchondral sclerosis. So if you compare it with this normal joint, right, the border of this joint or the subchondral means the cartilage is here. This blank space we see here is actually not blank. There is cartilage, right? So in osteoarthritis, the cartilage has got wasted and now the bones are touching, right? So subchondral means just below the cartilage. Just there's a sclerosis. So you can see sclerosis means addition of like bones, right? So there's thickening of the bone just below the cartilage area. So that is here. You can see a white line. So that is subchondral sclerosis, right? So what is the cyst we can see in other, it's not very visible here. Like you can see small the cysts. Again, these are subchondral cysts just below the joint, right? You don't get it like deeper down. You have to observe the X-ray just below here or here, right? So when they give you a question, this is how you differentiate, right? So osteoarthritis, mainly the distal, right? And it can also affect the first carpometacarpal or intercarpal joints. So you get osteoarthritis of intercarpal joints. You must have heard of that. So those are pathognomonic of osteoarthritis, distal interphalangeals, right? Rheumatoid is the metacarpophalangeal wrist joint, right, and the proximal interphalangeals, right, and it may affect this second row as well, right, but does not affect the distal. And in psoriatic, again, it's similar to osteoarthritis. It affects the distal joints. So how do you differentiate between psoriatic and osteoarthritis? Can anybody tell me? So they will give you a picture, osteoarthritis, arthritis affecting the distal interphalangeal joint. So then you're thinking of either psoriatic arthritis or osteoarthritis. But what is the differentiating point? Can anyone put it in the chat box even? Come on. Okay, so one is inflammatory arthritis, other one is mechanical arthritis. So even though the same joints are affected, the other associated features will be different, right? So inflammatory, like I said, stiffness is more than 1 hour. Here it's less than 30 minutes and improves with rest, worsens with rest, right? Or improves with activity versus either way. So just some pictures. This is an osteoarthritis. There's a joint space narrowing. So distal interphalangeal joints are affected, right? And then there's osteophytes. There is this joints jutting out from here are osteophytes. And then tiny cystic sort of lesions, you can see tiny circular lesions. Those are the subchondral cysts, right? This one is rheumatoid arthritis, right? So if you can see the difference here, the bones are very the shadows is darker here. So it's more see-through here. So there's osteopenia, and this is, there is no osteopenia. It's nice white bone, right? So this is osteoarthritis. So you can see the subchondral sclerosis, those white lines, right? And the loss of the joint space. Here there's joint deformity. And if you look closely at this, it's a ragged edge. The edges are very ragged, right? These edges here are very ragged. So these are these rat bite erosions, right? So this is a close-up of it, right? Marginal erosions and joint space narrowing. This is a normal joint versus the subchondral sclerosis. So you can see the whitening here, just below the cartilage, right? Osteophytes in osteoarthritis. So I'm just showing you some x-rays so that when you get an x-ray, you're able to identify these things, right? So osteophytes. These are the subchondral cysts, right? So when you keep looking at them, you'll be able to figure it out. So always go with the history and the x-ray picture, right? So before we get into the next group of diseases, we'll take like a 15-minute break and we'll be back, right? So it's 6:53. We'll start around 7:05, right? And you all can put any questions on the chat box if you all want to. Right? So I'll be starting anyway till everybody joins. Anyway, I'll be getting a recording of this. I think you all have some short access to the lecture as well. Uh, so I'll just get going. Otherwise, we won't be able to complete it before the time is up, right? So again, in SLE, what you need to know, uh, there's some clinical criteria that you go by, right? First thing, it affects females mostly, and the ratio of female to male is 9:1, right? And you get some cutaneous manifestations, oral ulcers, the alopecia, right? And then joint involvement, right? Synovitis, so inflammatory joint involvements. Serositis that will affect your, say, the lungs, the myocardium. It can lead to effusions. Any serositis will lead to effusions, right? Renal involvement, neurological involvement, and you get anemia. So anemia here is uh, hemolytic anemia. So Coombs positive, right? And leukopenia is less than 4,000, thrombocytopenia less than 100,000, right? So again, no need to memorize, just this is a recall, right? So we've all done this at some point, and we just need to recall this so that when it comes in a question, we are able to connect it, right? So they are not going to ask you, uh, does SLE cause non-scarring alopecia? No, they'll give it to you in a question, and they might ask you the management, right? So, immunological criteria, we need to think about the ANA, anti-dsDNA, right? So, ANA is not specific. Up to 15% of the population can have uh, positive ANA with no underlying clinical condition. And dsDNA is more specific. So if ANA is positive and dsDNA is positive, it's highly likely that it's an SLE. But the confirmatory here is anti-Smith antibody, right? So this is an MCQ question. So the confirmatory investigation is anti-Smith antibody. And during flare-ups, you will get uh, low complement levels, right? And they can have associated antiphospholipid antibody syndrome. So associated with SLE is antiphospholipid antibody syndrome. So this is where there is a coagulopathy, coagulopathy in the blood. So they will have recurrent miscarriages, Raynaud's phenomenon, and various other features, right? So this can be associated with SLE. And here direct Coombs test is positive. So for diagnosis, you need 4 more of these criteria, right? 1 clinical and 1 laboratory at least within that 4, right? So it can't be 4 from only one side, right? So at least 1 should be present from the other side. And if it's a proven uh, lupus nephritis, that is biopsy proven lupus nephritis, you can go with fewer criteria than 4, right? So again, MCQ question.
right? Uh, what is the first line treatment in SLE? So this is an MCQ question. So it's HCQ, that is the first line treatment. Glucocorticoids can provide rapid symptom relief, but medium to long term aim is to minimize the dose to less than 7.5 milligrams per day, right? Or to be able to discontinue. So if you're unable to discontinue, your goal is to bring down that dose to less than 7.5. So you can bring down this dose by adding other drugs as well, right? So, but your first line is hydroxychloroquine in SLE. Subsequent initiation of immunosuppressive drugs facilitated the rapid tapering of glucocorticoids. So, when you are unable to bring down the steroids, you can add some other immunosuppressive agents, such as, so there's methotrexate, azathioprine, right? Uh, then MMF, this is a very potent immunosuppressant, right? So it's renal and non-renal SLE. It can be given, but it should be avoided in neuropsychiatric lupus, right? Cyclophosphamide is considered when there is involvement of organs, right? Like renal, cardiopulmonary, or even neuropsychiatric, you can give cyclophosphamide, right? So the European guideline, they recommend even going for MAB therapy, that is biological agents, that is Belexmumab and rituximab, right? So just remember there are two MAB therapies that have been recommended as well. So this is again an MCQ. I've highlighted the points that are needed. One is so the what we need to know is that in anti-Rho and anti-La positive SLE, when they conceive or when the baby is born, are also affected by these autoantibodies. So it crosses the placenta, it can affect the babies in utero. And when they are born, there's two very specific conditions in babies born to mothers with anti-Rho, anti-La positive SLE, is they can develop bradycardia, right? So there is atrioventricular blocks or congenital, it's called a congenital heart block. And the other thing is they can have neonatal lupus, that is cutaneous manifestations in the neonatal period, right? So this is because the mother's antibodies are acting on the child, right? So one is cutaneous lupus or neonatal lupus, other one is congenital heart disease, heart block, right? So 80 to 95% of the cases of severe AV block occur in the neonatal period. Presentation of cutaneous manifestations range between 7 to 16 of the mothers who are positive for anti-Rho and anti-La. And of these antibodies, uh, you can get it in even in healthy women, and 90%. So this is a large figure. 90% of this anti-Rho and anti-La is seen in Sjogren's syndrome, 20 to 30% only in systemic lupus erythematosus, and 3% in rheumatoid arthritis. So why is this important? Is because they can give you a patient with Sjogren's syndrome and the child born has an AV block, right? So again, it's because of these autoantibodies. So, but it's well known with SLE. So right now there's a question with SLE and the child having a congenital heart block, right? So so far, so this is very important. This has come in the past question where there is they say there's no specific epitope responsible for SLE, but there's a greater role of anti-Rho, right? So the question that we have, it says there's one stem that gives you the option of anti-Rho and the next stem gives you the option of anti-La. So because we know both of it causes AV block, we get confused about which one to pick. But this is The only thing that we can find is from it's from an NIH guideline, right? Sorry, research article. So the role is greater with anti-rho, right? So if you take septic arthritis, so these the rest of the arthritis is just a matter of knowing a few symptoms that will help you differentiate it between other arthritis, right? So rapid destruction of one joint with extensive erosions and effusion is one of the key features of septic arthritis. It's a very rapidly progressing disease, right? So septic arthritis is also known as infectious arthritis, right? It's a monoarthritis. So it's an acute monoarthritis. It affects single joints, right? And it occurs secondary to some infection, some bacteremia or a local, like a wound that has spread, right? So there's very rapid joint destruction in the sense the bone gets destroyed or eroded overnight if you don't start antibiotics immediately, right? So radiological findings, just know there'll be joint effusions, and there can be gas within the joint. Uh, there's also osteoporosis features and erosions and joint space narrowing. So this is important, right? Uh, Cartilage destruction. So that is why there is a joint space narrowing, right? Uh, Monoarthritis is important. So most commonly occurs in the knees in adults, and in children it can occur in knees and hips, right? And up to 12 months, it has been seen common in infants up to 12 months, right? So there can be, so when they give you the question, they will give you a feature such as fever, right? Associated. So there'll be a high spiking fever with chills and rigor, right? Suggestive of bacteremia. And then soft tissue, there is warmth, swelling, tenderness, right? All those features. So remember that is then septic arthritis. And what are the seronegative spondyloarthritis? So seronegative, what is the meaning of seronegative spondyloarthritis? Seronegative meaning the rheumatoid factor is negative, right? That is what they mean by seronegative. So rheumatoid factor is negative. So what is positive in most of these? It's HLA-B27 that is positive, right? So like in ankylosing spondylitis. So this seronegative arthritis is classified into axial and peripheral. So the axial we all know is ankylosing spondylitis, and the peripheral is what we need to know for the exam is psoriatic and reactive arthritis, right? So a little bit about ankylosing spondylitis. Basically, you need to know the X-ray findings mostly, right? So it's axial arthritis and associated with enthesitis. So what is enthesitis? That is like the inflammation of the tendon at its insertion, right? Where it's touching the bone, that part of the tendon is inflamed and painful, right? So that is what leads to these shiny corners in the X-ray, right? So you get something called shiny corners in the X-ray. That is due to the edema associated with the enthesitis, right? Then you get something called syndesmophytes, which are bony sort of protrusions, and then these will fuse and cause fusion of the bones. And then there's also inflammation of the soft tissue around the sacroiliac joint. So sacroiliitis is one of the key features of ankylosing spondylitis, and it can be diagnosed. Of course, there will be tenderness on palpation. Other thing is it can be diagnosed on an MRI, right? So if you see sacroiliitis, it's almost always ankylosing spondylitis, right? So they come with features of significant back pain, morning stiffness, and disability. So they have morning stiffness too, and they have severe disability due to the fusion of the joints, right? and this is the common onset, right? Third and fourth decade. So third decade means in their 20s, right? So it starts very young. It's a juvenile art sort of thing, where it starts in their early 20s. Uh, so primarily affects the spine and the SI joint. So these are the joints that you're talking about when you're thinking of ankylosing spondylitis, right? Although other joints like shoulder, hip, rib, heels are also affected, right? So they can be affected. So this is the radiological findings. We go through some x-rays so that if they give you an x-ray, you can always come to a diagnosis, right? So clinical features, what we spoke, and then there's pain at rest. This night pain is important in ankylosing spondylitis. Stiffness, again, it's inflammatory, right? So it's more than 30 minutes. Alternating gluteal pains, arthritis, enthesitis, especially where it joins the heel, right? Where the tendon joins near the heel. And there are some extra articular manifestations as well. Dactylitis, psoriasis can be associated, right? Crohn's disease, and they respond well to NSAIDs, right? Family history, because HLA-B27 is a genetic thing, right? So this is again from their guideline. Peripheral arthritis occurs in all variants, right? So you can have peripheral arthritis. Up to 50% of them will develop asymmetric oligoarthritis as well. So just because they give you this peripheral arthritis doesn't mean you can uh, exclude ankylosing spondylitis. It is definitely an axial arthritis. It affects the spine and the side joint, but remember in their question they can give you other joints being affected as well, right? Enthesitis or inflammation at the insertion of the tendons, ligaments, and joint capsules. Achilles tendonitis. So this is where you get the heel pain, right? Plantar fasciitis, again heel pain, and then intercostal enthesitis, right? So that is around the ribs, which causes chest wall pain. Then you can get dactylitis. These are sausage digits where the fingers are swollen and inflamed, right? It's due to tenosynovitis of the digital flexor tendon. So this can also be seen in psoriatic arthritis and reactive arthritis, right? So the flexor tendon inflammation can be seen in psoriatic and reactive arthritis as well. So other extraaxial features, uveitis, right? Which is mostly uniocular. So you see uveitis in one side, right? And it's pretty common. It occurs in 40% of the patients with acute painful red eye, blurred vision, photophobia. So we will be doing that in more depth when we are doing ophthalmology, where they will give you a patient comes with painful red eye. So what are your differentials when they come with painful red eye? What are the other features that you look for? How do you come to diagnosis, right? So this is, remember, one reason for uh, one reason for painful red eye is anterior uveitis. So they sometimes give you a picture of an eye only, and you should be able to look at that eye and identify the features of anterior uveitis. So we'll do it when we're doing ophthalmology. Those ragged edges, how you find those, right? First line treatment is a combination of corticosteroid and mydriatic eye drops. So this has been an MCQ. Anterior uveitis, what is your first line treatment? Right? So this has been a past question, right? Combination of steroid and mydriatic drops, right? About 60%, more than half of the patients have a mucosal inflammation on colonoscopy. So there is inflammatory bowel disease. So IBS also has an association with HLA-B27. If you can recall from your final this thing, inflammatory bowel disease has HLA-B27 association, right? So, but 60% of them will have inflammation but only out of that, only 10% will have this inflammatory bowel disease. So IBS is an association. These two I particularly put it because these have been MCQs, right? So they can have osteopenia and osteoporosis, right? Again, just like rheumatoid arthritis, where you get osteopenia, osteoporosis, affect the lung, affect the aortic valve. So this is aortic valve incompetence is a common, it's a finding association with ankylosis spondylitis. So if you diagnose AS, you need to do a 2D echo, right, and exclude this AV regurgitation, basically aortic valve incompetence, right? So this is from the RSAGP guidelines, inflammatory versus mechanical, right? So how it's insidious, mostly in inflammatory, improves with exercise, improves with rest in mechanical, morning stiffness, it persists for more than 40, actually 30 minutes you can take, but in their guideline they mentioned 45 minutes. This is from the new EULA guideline. And then mechanical one is short-lived stiffness, right? So inflammatory markers are mostly elevated, obviously, in the inflammatory arthritis, but you CRP and ESR are normal in osteoarthritis or other mechanical arthritis, right? So again, this kind of flow chart is there in most of those RSA GP guidelines. So when you're going through the guidelines, try to remember these flow charts, right? So it will really help. So these are some of the features of spondylosing arthritis, right? Back pain, right? So young patient in his 20s coming with chronic back pain even at night, right? So you need to think about um, ankylosis spondylitis. So arthritis enthesitis, uveitis, dactylitis, psoriasis. So this is all from the RSCGP guideline. Inflammatory bowel disease, all associated, and they respond well to NSAIDs, like I said, right? So investigations, HLA-B27, elevated CRP. So when you have these SPA features and say patient comes to you with chronic back pain, more than 3 months, young patient, right? Second and third decade, that is, right? Sacroiliitis, if you do an MRI, you can see inflammation of the sacroiliac joint, right? And one other of these features is suggestive of ankylosing spondylitis. So if you have an MRI with sacroiliitis, I said it's almost always true for ankylosing spondylitis. So you need only one more feature. But if it's just an HLA-B27 that you're done and it's positive, you need two features from this to diagnose, right? So symptoms, exercise, NSAIDs, and it has been shown that NSAIDs will slow the radiographic progression of, that is using regular NSAIDs, taking it daily as a daily dose, uh, whether it's BD or TTS or whatever, you're taking a regular dose, will slow the radiographic progression rather than taking only when you get the pain, right? So other one you can use is uh, tumor necrosis factors and go for DMARDs, right? So methotrexate and sulfasalazine have little effect on spinal disease. So there's an MCQ on the treatment, right? So when you're choosing which treatment you're going to give the patient, you need to remember if it's spinal problem, giving methotrexate and sulfasalazine will have little effect. But if they have associated peripheral arthritis, so like we saw, it's not only axial involvement, you can get peripheral arthritis, then have giving DMARD such as methotrexate and sulfasalazine can help, right? So advanced disease, initially stages you can give NSAIDs, advanced disease you can go for tumor necrosis factors, peripheral joint involvement you can go for methotrexate and sulfasalazine. So remember that. That is also one of the past paper questions, right? Uh,
So we have here some features, right? So joint fusion, sacroiliitis. We look at some X-rays. So this is from the RSAGP guidelines picture. Uh, so as you can see, these edges are rounded, right? So those are called shiny corners. This uh, there's another thing called early syndesmophyte. So these are those uh, jutting out. You can see these spurs, like bony spurs jutting out from these edges. These are known as syndesmophytes. These also can fuse. So it's these syndesmophytes when it's basically calcium deposition on this vertebral discs, right? So you can see like bony outwards. When these become very prominent, this is what leads to what you can see on the X-ray as bamboo spine, right? And then there's fusion of these spines, right? So the spine of the vertebra tends to fuse. So, and then you can get some sclerosis, joint erosions, all of that, right? So this is sort of a depiction of uh, an ankylosing spondylitis joint, right? Syndesmophytes, these are those jutting out portions in the bones. These are the syndesmophytes. So we'll share these guidelines with you also. You can go through because I've taken most of it from the guidelines. So reactive arthritis, uh, this is a sterile arthritis. So if you get like a monoarthritis, even if it's sterile, then it's reactive arthritis, right? So it can come after an infection elsewhere in the body. That is what after a history of a diarrhea, history of UTI, right? They can get uh, arthritis at least 1 or 2 weeks after having a diarrhea or UTI, right? So this is known as reactive. And then uh, there is some cross reaction between the bacteria that cause the diarrhea or the UTI and the synovial tissue. So they will uh, basically attack the synovial tissue as well. So the antibodies that were formed in the body to fight this GU infection or the diarrhea will later go and attack the synovial joint, confusing it for the bacteria, right? So this is why it develops after the disease, right? Classically, patients will present with, there's a triad. So for reactive arthritis, there's a triad. And the mnemonic to remember that is can't see, can't pee, can't bend the knee. Right? So can't bend the knee is the arthritis. Can't pee is you will have a dysuria or a urethritis, right? And then can't see is you'll have a conjunctivitis, right? So that is the triad. Asymmetrical arthritis, it can be monoarthritis, urethritis. Another associated one is cervicitis. So you can have cervicitis or urethritis and conjunctivitis. Right? Diarrhea is not a part of it. Diarrhea will be the past history, right? And then you can get other associated stuff also like this, right? So, uh, sorry, this is just all in one. So another name for reactive arthritis is Reiter's syndrome, right? It's again commonly seen with those who have HLA-B27, right? So it's associated with seronegative arthritis. It's a reaction to either GI infections or genitourinary infection, or it can be secondary to chlamydia STD as well, right? So the GI bacteria that whose antibodies would cross-react would be Shigella, Salmonella, and Campylobacter, right? So these are the infections. Uh, Treatment is basically NSAIDs only.
steroids are not considered, right, unless it's like really severe. So NSAIDs is your first line treatment. So AMC will always ask you what's your first line treatment. So it's always NSAIDs, right? Synovial fluid aspiration will show you that it's a sterile arthritis, right? So when you do culture and sensitivity, right? So your only reason you're doing that is to differentiate it with septic arthritis. So all of this was in that image. So there's HLA-B27. This is the triad, but it's not present in all cases. So remember that does not have to have the triad always, right? So then what are the triggers? We saw it in the diagram itself. Commonly involves the lower limbs, and that is mainly the knee joint, right? And there can be erythema around the joint. So self-limiting, but you need NSAIDs as your first line, right? So you can check the RSAGP guidelines. This is the ankylosing spondylitis. So you can just go through. These are not like absolutely necessary for, but just know there's the Scobus test just to recall what you have done in the past, right? Difficulty inflection onto the side, right? There are some extra articular, extra axial features, and these are some of the X-ray findings, right? So this is what I put on the slide. And the MRI, how it's shows sacroiliitis, and there are some genetic stuff. So this is from the guidelines, right? So this is for JIA that will be done with pediatrics. Reactive arthritis. This is a little bit. I have taken everything onto the slide, so you don't have to worry. Right. So whatever you need to know, you don't need to know all of these, right? So they are given a little comparison. You can go through it, right? So these ages are important when you're doing pediatrics, right? So I will do it with the ped section. So yeah, this whatever was needed was taken to the slide, right? So how you have to give, how you have to be aware when giving methotrexate, contraindicated in pregnancy, right? So and you need to give counseling regarding contraception uh, and disease control during pregnancy. So any patient getting methotrexate or any other teratogenic agent, you need to give them counseling, right? That has come in one of the questions in relation to tretinoin for skin disease, right? So a little bit of psoriatic arthritis. The reason you need to know this is to be able to exclude, right? Uh, so this is again from RSAGP guidelines, right? The comorbidities associated stuff with psoriasis is when you have psoriasis in the skin, you get some associations. That is arthritis, any cardiovascular, inflammatory bowel disease, celiac disease. It can even affect the mental health, right? Diabetes, hypertension, and then they can end up with obesity. And due to the persistent psoriasis, they go into depression, right? And they go into substance abuse, gambling, right? So with chronic treatment, it can affect the kidneys and the liver, right? This non-melanoma skin cancers is because of the psoriasis, that is the skin-related psoriasis, when they are constantly being treated with the particular drugs that are being given. We'll do it during dermatology. And then you get exposed to sun, so the chance of getting skin cancers are higher. So they need to use sunscreen, right?
Psoriatic arthritis is a chronic inflammatory spondyloarthropathy. About 42% of patients with psoriasis, right? So these figures are from their guidelines. Symptoms include pain and stiffness at rest and improves with movement. So it's inflammatory, right? Morning stiffness, though, will last longer than 30 minutes, right? But it improves with movement. 5 types of PSA are you can get oligoarticular, symmetrical, distal, right? So you can get any spondyloarthritis fusion of the joints can also occur, right? That's in very severe diseases, or you can get any joint deformities, arthritis mutilans. So even in PSA, you get enthesitis and dactylitis. So you saw it in ankylosing spondylitis, you're saying it in psoriatic. But here you get nail changes, right? And uh, what you need to know is it's associated with HLA B27. So that's why there's an association with ankylosing spondylitis as well. PSA is considered a spondyloarthropathy because of the extra-articular features of spondylitis that happen in 40%. So joint fusion can occur in 40% of the patients, right? So this pencil cup deformity, I couldn't put a picture. No, I couldn't put a picture. It's commonly seen in uh, psoriatic arthritis. That is like when you look at the X-ray of the finger, uh, due to the joint erosion, it feels like there's a very thin bone in a large cup. So like a pencil inside a cup, right? So this is what we saw metabolic from their guidelines, right? Metabolic syndrome features, then they can have we saw it, they were into gambling, alcoholism, smoking, depression, their mental health disorders can affect these organs, right? So this is just, I put it into, I got this picture because it has everything in one picture, right? So remember, this is from their guidelines. It psoriasis, that is the skin disorder, uh, precedes psoriatic arthritis by almost 12 years. So what they're saying is there's enough time for us to ask the patients about the symptoms of arthritis and investigate it and treat early in the disease before there's permanent joint destruction. So permanent joint destruction is very rare because they are constantly on the lookout for this because it takes 12 years to develop PSA after having the skin lesion, right? So one of the things you have to remember when you're answering the MCQs is in a patient with psoriasis, one of the concerns is psoriatic arthritis. So you need to treat it early before there's joint destruction. So gout and pseudogout, there's been quite a lot of questions again. Uh, and most of them are straight off the guidelines. So I will share these links later, and I've taken everything that you need from the guideline onto the slides, right? So uh, one thing you need to remember, gout, even though they say grade 2, it doesn't only occur in the grade 2. So there have been MCQ questions that are showing you that the answer is gout, but it has occurred in the knee joint, right? So you need to be able to differentiate between gout and pseudogout. All this is a common initial site, right? So it affects any joint in the body and even mimic polyarthritis or rheumatoid arthritis. So it can be similar to both, right? So gout is associated with other comorbidities. So remember, when they are giving you the question of gout, they will give the patient with a background of hypertension, DM, kidney disease, right? So this is important, kidney disease, because there are certain gout treatments that cannot be given in those with renal disease, right? So another thing you need to think about is when you're giving treatment for gout, that there are some drugs that alter the efficacy of those treatments. So one is if you give drugs that raise the serum urate levels, it can your treatment will become ineffective, right? So that is thiazide and loop diuretics. So people on long term these drugs can also develop gout later. Then there are certain drugs that impair the actions of this. What are these urate lowering drugs? This is allopurinol, right? Allopurinol is your urate lowering drug. So its action is impaired by furosemide. So maybe it gets washed out, right? So another thing is losartan helps to lower the serum urate. So when you're giving urate lowering drugs, you need to think if the patient is on losartan already, then you can start with a smaller dose. So you're going to reach your target urate level faster if they're on losartan, right? So you need to consider their comorbid conditions when they're treatment, right? When you start their treatment. So that is very important because there are lots of MCQs that will give you different comorbidities. And then you have to really think about what is your first line of treatment, right? So it's not fixed. There is a fixed first line treatment, but it depends on the comorbidities, right? So this is the target serum urate levels, right? With tophi, without tophi, right? So again, from the guidelines, so this slide is really important. It will help you answer a lot of the MCQs, right? Treatment of acute flare should begin as soon as possible. NSAIDs or colchicine are the first line. So remember, NSAIDs or colchicine is first line. Then oral corticosteroids, when do you give? It is for those who cannot tolerate or have contraindication to first line. So in case of gout, if they have any contraindication to these two, you go for steroids, right? So you give it at full dose NSAIDs, and colchicine is given like a bolus dose immediately, and then you start giving it 6 hours later, lower dose, right? So for colchicine, for you to start colchicine or even NSAIDs, you need to have a normal renal function, right? So if you have any GI problems, right? So it is not associated with GI problems, but if they're having peptic ulcer disease, you cannot go for NSAIDs and corticosteroids, right? So these have been MCQs, a patient with peptic ulcer disease. So remember, peptic ulcer disease, you cannot give NSAIDs, you cannot give corticosteroids. And here they say colchicine usually is not usually associated with GI adverse effects, right? So if they give you a question with a patient having peptic ulcer disease, your choice will be colchicine because it does not affect uh, gastrointestinal, doesn't have any GI adverse effects, right? Even lower colchicine doses are required for those with renal impairment. So you generally can give it only in normal renal function, but if there is renal impairment, you still can give in low doses. But if GFR is less than 30, you have to completely avoid colchicine, right? So if there's multiple joint involvement, you can consider oral steroids, again an MCQ, right? When do you give oral? When you give intra-articular. So oral steroids is if there's multiple joint inflammation. If there's one or two joints, you can try intra-articular injections, right? So if there's monoarthritis. So remember that where it is contraindicated, right? Otherwise, first line is NSAIDs or colchicine. Allopurinol. So in the past, what they thought was a known patient with gout who is already on allopurinol. In the past, what they said was you need to stop the allopurinol during the flares. But the most recent guidelines say you don't. So even in the RSAGP guideline, no stopping of allopurinol during the acute flares, right? So even if the patient has come to you first time with this with gout, not a known patient, now you have diagnosed gout, you can even start allopurinol during the acute flare, right? But you have to combine it with the acute treatment. So remember, gout, there's an acute treatment, also there is a long-term maintenance treatments. The long-term maintenance treatment is allopurinol. The acute treatment is what we saw. So this is acute flare treatments. This is NSAIDs colchicine. Allopurinol is your maintenance treatment. But when you come with a flare, for the first time, you can start allopurinol at the same time. So in the past, they said you cannot start until the inflammation becomes normal, right? Until you reach your target urate level. Now they say you can start it all together, right? So here, this is all from their guideline. Evidence suggests that it is the starting dose of allopurinol, not the maintenance, that increases the risk of allopurinol hypersensitivity syndrome. So there's something called allopurinol hypersensitivity syndrome, right? Again, a past paper question. Therefore, allopurinol should not be started at 50 to 100 per day, should be started at 50 to 100 per day. So you don't start off at high doses. You start with low doses, and generally you go with 100 milligrams per day. And if there is chronic kidney disease, you have to go with 50 milligrams per day, right? And titrated up every 2 to 5 weeks. So you're titrating it till you reach the target urate level that we saw, right? So, allopurinol hypersensitivity syndrome is seen in those who carry this particular allele for the HLA gene, right? So, again, from their guidelines, this has shown an increase. This is supposed to be more in those with Asian descent. So, their guidelines are recommending to test for this allele in those who have high risk, like those with Asian descent or with renal impairment, and avoiding allopurinol if they have any positive HLA-B5801, this allele, right? If it's positive, you have to completely avoid allopurinol. And if renal impairment is, especially if EGFR is less than 30, you avoid allopurinol, right? The next drug you can go for instead of allopurinol for maintenance is febuxostat. So that is a newer drug, right? Those who have hypersensitivity syndrome, right, or any allopurinol rash, or those who have this allele positive, you can go for this drug, right? So pseudo gout, as opposed to gout, it's known as the calcium. CPPD is calcium pyrophosphate deposition disease, right? So between the joint in the synovial fluid, you get this calcium pyrophosphate deposition, right? So this is what you see as a fluff. So when you get this image at the exam, what they do is they give you a background history that is similar to gout, but they'll give you this X-ray. So this X-ray will suggest it's otherwise. So you don't get this kind of interspace, this calcium pyrophosphate deposition. This is the fluffy exudate you see, right? So this is pseudo gout. It's the symptoms, you get extremely severe pain, redness, warmth. So they will give you a picture that is similar to septic arthritis. So when they come with gout or pseudo gout, again, another thing that you will be thinking about is septic arthritis. But how do you differentiate the fever, right? So if there's no fever, you can exclude septic arthritis, right? Knee is most commonly affected in pseudogout, but can occur in other large joints as well, right? So they can give you any joint for pseudogout in the questions, right? So for gout, normally they have family history, they have obesity, hypertension, DM, dyslipidemia, kidney disease, they may be on thiazide diuretics, right? But in pseudogout, it's could be a past history of trauma, right? Family history again, hemochromatosis and other metabolic diseases such as thyroid diseases, right? So don't go directly by these also. So you will have some questions that are giving you these features, but they'll give you an X-ray of pseudogout, right? So this is again MCQ questions. They have asked about the crystal types. So needle shape, negative birefringence is monosodium urate crystals, that is in gout. Calcium pyrophosphate crystals are found in pseudogout. They are rhomboid shaped, positive birefringence, right? So remember the two references. Needle is negative, right? Again, gout and pseudogout, there are differences in one picture, right? So you can see even the X-ray, this gout, you get some joint destruction as well. Rat bite erosions are seen even in gout. And then you get this fluff present in pseudogout. So this is known as chondrocalcinosis. Chondro means the cartilage, right? So Sjogren's disease, you just need to know to differentiate it. Remember how you remember it as this O here is written with the two dots on top generally, Sjogren's disease. So we remember this as the two eyes and this is the mouth, right? So they have lack of tears, lack of salivation. Eye, no tears, mouth, no salivation, right? So it affects mainly those two, but there are other organs affected. So this is the other extra articular features of Sjogren's syndrome. Like I said, they are associated with rheumatoid arthritis, Raynaud's phenomenon, right? All of this can occur together. But the main features are dry mouth, dry eyes, and arthritis, right? So that is their triad: dry mouth, dry eyes, and arthritis. So secondary one can occur due to any of these associations, right? SLE, rheumatoid arthritis, scleroderma, polymyositis. So any of these associations can lead to Sjogren's. So if you can recall, we said Sjogren's syndrome, 90%, remember that slide said 90% had anti-Rho and anti-La positive, right? So they can also have babies who have congenital heart block or cutaneous lupus, such of effects, right? Congenital heart block mainly, right? So that is just an idea into the Sjogren's syndrome, so that it comes in stems, right? So they haven't asked particular questions about it. So this is basically majority of the rheumatology stuff. We'll be doing the questions on Saturday, right? On Saturday, if there are certain topics that have been only asked once or twice, we'll be doing that also additionally, right? So that by then we have covered the whole section of rheumatology, right? So we'll go through with these slides and do the questions on Saturday, right? Okay, thank you.